I'm Wilma, and I work since many years for MSF. Worked always as a medical coordinator, and since a couple of years I work in the operational research unit within OCB, and doing research in all kinds of topics. And this was to my heart, as I had been the medico in Burundi, where we had a neonatal care unit. Now, if you think, okay, now we're going to get a presentation on how does it work, neonatal care in MSF, I'm sorry I have to disappoint you, because this study is about what's happening after. 2 years after low birth weight babies had been discharged from a specialized neonatal care unit, or I use the word low technology, meaning there's no incubators, there are no mechanical ventilation, so it's really low technology neonatal care units. What happens with these babies 2 years after? So small introduction to Burundi. It's a small country in Central Africa. High neonatal mortality rate. The main causes, as almost everywhere in low-income countries, for neonates. And the emergency obstetric and neonatal care unit was in Bujumbura rural province, where in Kabezi district we had this center, and in the neonatal special care unit we decreased mortality for the low birth weights with 15%. So now what's happening with these kids afterwards? And in order to determine that, we were looking into mortality, into Sequelae, in a potential burden to the family, and the nutritional status. This was a household survey using a structured questionnaire, and I come back later to how that looks like, this questionnaire. And the study was done in 2014 on children who had left the neonatal care unit in 2012, and it was for the low birth weights only, and who were residing in Bujumbura rural province. So in 2012, there were 146 low birth weight neonates discharged. And 11% were not known to the village leader when we arrived in these villages. And this is possibly due to that mothers had given at the time false addresses in order to be falling into the program criteria. 8% of the patient files could not have been found, so we couldn't find the detailed addresses of these patients. And 3% of the children had migrated out of the catchment area. So that left us with 113 children. Of these 130 children, 6 had died. And the median survival was 183 days. But as you can see, one child had already died 10 days after being discharged from our neonatal care unit. And the possible causes mentioned by the mothers were infection, respiratory related, and one even unknown. It died on the back of the mother. Of the remaining 107 children, the baseline characteristics were slightly more females. Their median birth weight was 2,020 grams, with 7 less than 1,500 grams. And their hospitalization indications were, well, obviously a more premature or dismature, 55%, prenatal asphyxia 11%, neonatal sepsis 10%, and risk of infections of 18%. Now for Sequelae, so this was a specific tool which is actually being used as part of the UNICEF's multiple indicator cluster survey. So it's 10 questions which screens a child with disability. And these questions are related to motoric, mental, speech and intellectual development, and visual and hearing impairment. So a question is asked to the mother or the caretaker with a yes or no question. And if there is a yes given, that's a positive result. And if 1 out of these 10 is answered positively, then that is an indication for an increased risk of disability. And the question was always compared to a child of the same age. We wanted to know more. We wanted to know, do these low birth weight babies who had been hospitalized in a low technology unit, do they cause a burden on the family after discharge? Now, a burden on a child, that's not done. A child is never a burden to a mother in Africa. So we needed to find some proxy questions in order to get to that point. And after pre-testing, those 3 questions were the most coming close to that answer. That was needs always assistance. So the baby cannot be left with a sibling. As we know in Africa, a baby can be left with a sibling between 6 and 10 years old easily. If that was not possible, that causes a burden on the family. The infant cannot eat by himself, or the caretaker needs to reorganize his life, meaning cannot go to the market or possibly having difficulties for working in the field. So these are the results of the Sequelae. This is in the order of the questions being asked from 1 to 10, and not in order of appearance. And we see that the motor development was in 17% of the children prevalent. And this was followed by number 7, learning, 8, speech, and 9, name at least one object in 12%. You see that the number in 8 and 9, the number was 73 only, and that's because not all the children had reached the age of 2 years, and so they were excluded for that assessment. If we put that in summary, then we saw that at least one development impairment was found in a total of 29 infants. And 5 or more impairments were observed in 9 infants. Is this a lot? We can discuss about that. But I also would like to highlight that 73% of these vulnerable children being discharged had no Sequelae. Was there an extra burden on the family? I think it's not so much surprising that those kids who had 5 impairments or more were those who were actually causing the burden on the family. So in 8 families, the child needed always assistance, cannot be left alone. In 5 families, the child could not eat by himself, and in 6 families, the caretaker had to reorganize his life. Now I skip this one to adhere to the timing of this session. This picture is just illustrating what it meant. You see these twins sitting on the ground, and those are actually 2 years old. And those were just about to be able to sit by themselves and to eat by themselves. And on the back of the mother, you see a baby, and that baby is 6 months old. And if you see, they almost look at the same age. And you can imagine that this causes a burden to the family. In terms of malnutrition, we saw global acute malnutrition of 18%, of which 4% severe acute malnutrition, so it is way above the thresholds for malnutrition. To conclude, we still would like to say that most of the infants were doing well after 2 years, despite a quarter hadn't been found. And that 3 in 10 with a development impairment, especially for low birth weights, needed continued individual and household support. And the high rate of malnutrition needs focused attention. Now, what does this mean in terms of policy and practice? If we set up a neonatal care unit, we should not only think until the end, when they are discharged. The care has to carry on after discharge from a special neonatal care unit. A network should be created with relevant partners involving special services, for instance, in feeding programs, or NGOs dealing with education and revalidation, or Ministry of Solidarity for social and financial support. And if you think, yeah, right, rural Africa, can we actually find this? Well, you would be surprised, but we found that this was all available in this rural district. And we only found it out during the survey and not whilst we were implementing our activities. So you can see there's a huge gap here. And then community engagement should be enhanced. And I would like to finalize with this slide that we thank the research team and especially the community health workers, that if they wouldn't have been there, we wouldn't have been able to find these children back. And last but not least, the caretakers of the children who said, they thanked us that we were actually still showing interest 2 years after they had been discharged from our center. thank you very much.
Thanks, Dr. Wilma. We will take 2 questions for clarification. Comments maybe will be after all the presentations. 1 and 2. 1 and 2.
Thank you very much.
Please, come on.
My name's Liz. I'm a paediatric emergency registrar in the UK. I thought that was a really interesting and very important piece of work you just presented. I've been involved in a similar study that's taking place in Port-au-Prince with OCA, and I was wondering if there had been any intersectional collaboration, or in the future whether there was any possibility when we're doing studies like this to allow us to publish sort of bigger pieces of work.
I have been for OCG in Haiti, and so that is still in the process. And their follow-up has been included for children who were put in a follow-up program. And of course, OCA is there as well, so it would be very great to do so. I think it's much more stronger to get the OCs together. Yeah.
Thank you. Here, madam. Yeah, here. Here, in the second row, in the middle. Sorry, we can't hear.
Merci, Mayam Silla du Mali. Belle étude. Nous avons aussi une unité kangourou, mais j'ai une question. C'était seulement un questionnaire adressé aux mères, ou est-ce qu'il y avait un score pour évaluer le développement de ces enfants quand je vois tous les résultats qui ont été portés?
Okay, the question is on whether the methodology being used was just asking a question to the mother, or whether a special score had been used for getting to these results. It was asking the question to the mother, and sometimes the interviewer could answer by observation, and it was a yes or no, and then it was adding up. One impairment was a condition for saying this is a risk for a disability. It's a screening tool. It's not, it doesn't say you are disabled. It's a screening tool for disability. So if the child would be starting to sit only at the age of 12 months, so that would be a positive result, and that positive result was adding into those statistics.
Thank you.